We shall have Mr. Kwako Martin to guide how the regions will be analyzing their indicators. And after that, we shall get one regional referral hospital to give us the discussions we had. And then we shall also have discussions on how we are going to operationalize the service. And after those discussions, we shall enter into the mode of closure. And closure, we shall have representatives from the partners, HDPs, to give closing remarks, UNICEF, CDC, and UNFPA, and we shall close this event officially. So in short, we have started scaling down to retire this event and to start our talk of guns. But I must emphasize that according to our agenda and program for this event, which is annually, the official checkout time from the hotels is tomorrow. So if you feel that you don't have anything to do at home, you want to relax, you will check out early morning tomorrow. If you feel you want to go back home and breastfeed, then when you close. But we advise the participants to avoid moving late in the night because it is safer to move during the day and to move during the morning hours. Thank you very much. John chapter 3 verse 16, for God so loved the world that gave his only Son, that whoever believes in him shall have eternal life and shall not perish. So Madam, can you give us a prayer for me here at the podium, not there? Thank you very much. Yesterday we had a lot of discussions, a lot of presentations regarding the HIV response sustainability. We saw the civil society plan for integrated community and service delivery. And all these discussions we are receiving the address from the Honorable Minister of Health, who graced the event. We launched the guidelines. We had also a Q&A, which formed part of the address from the Honorable Minister of Health. So can I now call upon Thank you very much. Can I call upon the rapporteurs to come and give us a recap of whatever took place yesterday, as I informed Mr. Martin Obama to be ready for the next presentation. So Dr. I will make sure that Mr. Obamo's presentation is ready. Rapporteur, come and give us a brief.
Would like to take you through a glimpse, just a glimpse of what has been happening from day 1 until day 4. So whatever you see is just some key points and discussions of what has happened, but there is a lot that has happened that we can only have it in a detailed report. So on our day one, we had some key points and guidance based on the different presentations that came up and the different panels, the presentation on integrated, the implementation strategy from the different partners, so those presentations that were made. So one of the key points really that stood out is to focus on creating a community health system that addresses the population health needs. So some of these points are to just guide us in our implementation and also to check out whether we really addressing the population health needs. And then the second point was to integrate public preventive medicine into the education curriculum. That is just fronting, being able to front the prevention arm of health in disease, especially in disease prevention and also health promotion. Then ensuring that the habits in the public health space are motivated and also are motivated to ensure their retention so that we are able to achieve the results that we require in the community health space. And I think that was well elaborated by the minister yesterday. And also to empower individuals to take charge of their own health through the behavior change communication. I think that was really a key, that as community, the individuals are at the center of our interventions, and that is very pivotal in thinking of how we are going to reach out to these communities or in continuing with our intervention in the partners or the district level or the regional level. Then to build our community health system. So that's what we're looking at, community health system that is resilient, able to withstand the different public health challenges and issues that may come. Then promote equitable delivery of health services across communities. And that is why we are doing mapping of partners to ensure that the different community health interventions are spread across the district and across the different regions to avoid duplication and also to optimize on the limited resources that we have. And also to incorporate health determinants such as climate modification into the community health strategies. That's clearly to bring up the concept of climate, since we all understand the past place, especially the community health factors. Then strengthen governance and leadership and management in community health, which is very pivotal, and move towards integration of health services into our unified system. Then to ensure that we work one work plan, one budget, and one monitoring and evaluation for implementation of integrated community health services. So that is the information and the message that we're taking from this. Then to adopt, to be able to encourage multi-sector collaboration to enhance service delivery. That was another key point. Adopt evidence-based practices emphasizing data utilization and research. And then to be able to innovate and sustain community health efforts, addressing the emerging public health concepts. Then to prioritize people-centered health services, emphasizing ownership of health by the different individuals, which are being key message throughout our briefing. To deliver the social service deliver the social service pillar of the parish government model to ensure that the community interventions reach out to the people at the parish level and the village level. Then to scale up community level monitoring systems. This will enable the population to be able to demand for services. Then strengthen the community health service delivery platform to improve the outcomes. And this is the reason as why we're here. All the efforts that we're trying to bring out is to strengthen the community health service delivery platform, because this is our key platform to enhance public-private partnership in the community health space, then implement the facility catchment area planning in communities, that's ensuring that the community are part of the planning process and being able to identify their own issues and identify solutions to those issues. And then mobilize resources for community health services through the RBA and the public laws, of which the tools we've been able to get indicators for community health in the RBA, so that will help us going forward in our implementation. Then to be able to identify and address research gaps within the community health space, and then less communities at the center of the goal, that's like what I'm saying, and strengthen the linkages between communities and community health department. So this is what came up here, and I think the meeting that the directors had with the referral hospitals going to help us see how that coordination can happen to the ground level to ensure that the integrated community health services are being delivered. Then also to align and implement the integrated essential community health service package. So as we're going out as partners, we are going to think through in our interventions how are we going to implement or how are we going to align to the integrated essential community health package. That should be the thought as we leave this place. Then to digitize the community health workforce to enhance efficiency. I remember one statement was made, if you can't digitize, maybe you can begin with the workforce that you have at the moment. Then promote timely data review and actionable responses. Involve the political leaders in the service delivery improvements. All of us know how pivotal it is. Then to create an indicator matrix for monitoring and evaluation, which is being the center of our discussions to ensure that we're able to monitor and evaluate our intervention to track our progress and to ensure that we're achieving the results that we are supposed to achieve. Best practices I've spoken about, then strengthening indicators between, that is all the referral system should really come out as clear on how we're going to coordinate the referral of cases at the community level. Then build health literacy. We will understand the key components also to integrate rehabilitation community level programming, then reach a consensus on strategic actions to achieve service integration. Then we have accountability, which I was talking about, and then still integrates. This is all to this really specifically for us to be able to bring all our efforts together to ensure that we have healthy populations in the community. Day 2 proceedings, we just had the same, the first point I have spoken about, the efforts geared towards creating responsive, resilient communities, which we've spoken about. The package keeps falling, or it's can help me. So, and then we have to adopt, which I've spoken about, unified health work plan. That is a key point that came up, and also to develop and disseminate standardized key messages for community health programming, and to deliver community health service packages effectively to the household. That as we're going out, households should be at our focus to reach out to ensure that all the interventions that we're doing in the community health space reach out to the households. Advocate for resource pooling, and then conduct a detailed costing of the community health service package to enable partners to offer support accordingly. Then leverage on established systems and institutions. This is for sustainability concerns, where we rate that despite the interventions that we partners are doing, it's important to leverage on the existing structure to ensure sustainability in case you are out or we run out or there is some shortage, the system or the structure that you build can still continue delivering the community health services. Then day 3, we had to strengthen community health interventions at grassroots. This was a key communication. And then evaluate the functionality of the committees under the PDM, focusing on the frequency of meetings, follow-up action, documentation, and health outcomes. And that is going to be going forward. That's the look into that going forward to ensure that PDM is a success. then assessing the health indicators. Then utilization of data was a key point that was emphasized. Despite we collecting data, we're supposed to be able to utilize data, assess the trends and the issues, public health concerns, and respond accordingly. Prioritize addressing all forms of malnutrition with serious and actionable intervention, since we've seen that it's a really key concern in the community. Then therefore, most of the things are almost our key points, which is the same which you're going to see them summarized in the word of declaration. And then we have therefore where the direction was given to us the future retreats in the community, and that was taken note of. Focus on prevention, which has been our discussion throughout the retreat, and then having model households, which has been hinted on, to be able to equip the community health workers and VATs to address the social determinants of health, and also to be able to cause demand for the different issues like water access, sanitation, hand washing also. Then the integration approach, which has been like a key discussion throughout, and I'm going to elaborate on that. And then to be able, one key point that also came up is to be able to set fixed allowances for the VATs, and so that every partner is able to give the same rate depending on the engagement. And then one plan, one budget is talking about the DHOs, and they were able to receive the message accordingly as stated in that, and then to be able to embrace the poverty elevation programs that have been set in the ground, like the yoga, the first development model, and have a clear career path for choose. Then to utilize statistics effectively in planning and to respond to community health, which I have also spoken about. Then encouraging us to take ownership to enforce the tobacco control, especially for the Yumbe case, and then also partner with the Ministry of Gender to tackle the issue of LGBTQ and also gender-related challenges. Then to be able to address the disparities, that was just what's going to be done for those districts in difficult terrain. Then align health initiatives with other government programs under the parish development model, emphasizing community ownership and participation. Otherwise, those are the key points that came up across the region, which they are all the same, speaking just and emphasizing on some key discussions that we're supposed to embrace as we go out to implement. Otherwise, thank you so much.
Madam, you're from which country?
Do it.
Okay, so as we are entering the technical part of it, we have to serve some more technical guidance before we call upon Mr. Martin. So I want to call upon Brenda to come and give us more technical guidance before we call upon Mr. Martin. That accent didn't seem very nice.
Good morning once again. Morning. Yes, finally we are here, day 5, and usually we finish strong because it's on day 5 that we declare the priorities for the next 12 months of implementing community programs. And so because we want to leave early, we are going to look at 3 main things. The first thing is that we had a program that was we left hanging on Wednesday. And for us as community health department, it's very critical because we want to deepen service delivery, but also we want to increase coordination of community health programs and programming. And so what we are going to do is that we are not going to call original farm hospitals, but first of all, let me appreciate regional farm hospitals taking this whole late, trying to look at how do they reorganize to their partners and also partners at the aid around. Thank you so much for your commitment. So, so what we are going to do, we are going to have the Ministry of Health, M&E Principal Officer, who manages our M&E throughout the ministry, just give us a glimpse on how the community health data looks like. Because going forward, from January next year, we are going to have monthly data and quarterly data analysis meetings per region. And within those meetings, we are going to be to make sure that we get indicators that we've not met, and we are going to start doing focused and targeted implementation throughout the country. And this is how important it is. So we are going to have Martin take us through the indicator and how they look like, and also the program that they've prepared, and the community health department and the planning department on the usage of data. And then thereafter, we shall have a representative of the community health departments, regional hospital, give us take us through how they plan to do coordination, so that we can guide them. Because whatever we guide, that's what we shall follow. Then immediately after that, we shall have a small brainstorming session on how we are going to implement or operationalize the national community health implementation guidelines. Because we want to integrate it within all your activities as we implement starting January next year. Starting, in fact, November this year, because UNICEF has already committed resources for some districts. Thank you, UNICEF, for being the first organization to actually implement. So that's how we are going to flow. Allow me to invite Martin. Martin, the floor is yours. Come and run us through. And then after Martin, Soroti, Regional Hospital, please prepare. Thank you.
Thank you, Brenda. Good morning, colleagues. My name is Martin Guago. I am a principal, the evaluation officer, with the Ministry of Health and Department Planning. On Wednesday, we had a presentation that we focused on sector-wide indicators. I was asked yesterday to just take us through show how our data looks like. And our focus this morning is going to highlight the process and output indicators at the village level, so that we get to appreciate the quality of data that we have, but also whatever is in there that we can use to improve outputs at that level. So our brief presentation is going to highlight majorly what we report on, or what VHTs report on quarterly. I know that we still have a lot of quality issues within the data, but at least we need to start from somewhere. My position, I mandated to just receive analysis. Usually don't do analysis myself because my programs are supposed to do that. But yesterday, as the request came in, I tried to reach out to our program person, Nick. Nick was not in a position to support us, so I did the analysis myself. And what I found there, I think, was an eye-opener. So I think we need to try and interest ourselves and look at what VHTs do as outputs there, and we try to support them. So this map kind of summarizes what VHTs did when it comes to children under 5. And we can see these are sick children under 5 that VHTs so attended 2. Okay? And this is by proportions, and the baseline is population estimates by that age category. And we can see that those in green they are doing fairly well compared to the numbers that they saw. When it comes to proportions, I think the regions highlighted in red, 14% Europe, 15% Elgon. We don't know, but I think the program people will dive in deeper and see what really happened. Those are numbers that are very few, or the sick children were very few in those regions. Still Uganda and Busoga, Kenya, the average are well. But these are the numbers in absolute figures. The total number of sick children under 5 that were seen by PhDs. And out of these numbers, we see that those that were found with fever, those percentages in the third column, 76% in Acholi, 85% in West Nile, 77% in Chigezi. So, if you analyze very well, Chigezi wouldn't expect, no, Chigezi is 34. Chigezi is 34, and Lamu was 77. And out of those that were found with malaria, with fever, those that received RDT we see that the highest was in Karamoja. The figures in the last column. So those malaria cases that were confirmed by RDT, majority of them were in Acholi, in Lamu, surprisingly in North Central, Kampala, 80%. But you see, in absolute numbers, Kampala is doing very badly. But when we turn it into proportions, you see that the very few numbers they saw were subjected to RDT. So we need to dive in deeper there and try to analyze. Out of those confirmed malaria cases, how many received SCT? So this is the treatment side of it. And we see in total, almost everyone that was confirmed to have malaria received SCT, received treatment. So it is interesting to just go through these figures and we try to understand what our PhDs do. There are not so many diarrheal cases identified, but if you can see clearly how many of those that were seen were found with diarrhea in the third column, you can see the numbers are low, but in Chigezi, 28% of those children under 5 that we are seeing where the PhD we have found with diarrhea, Kampala 33%, and Karamoja 25%. Out of these found with diarrhea, how many received orals, oralzine Copac. We see that still the numbers are high in Kampala, in Ankole, in North Central, Karamoja as well. So it is interesting to just get to understand the figures and the performance and support this. But most importantly, those that had diarrhea and were treated within 24 hours. Because it is critical to respond immediately. We see that the practice was good in Karamoja, 80% in Kapole, 80% in Teso as well, but we see Kampala is 16%. Was identified and treated within 24 hours. This is the distribution of the map, and you see the red is dominant in Uganda, Soga, Toro, and Union. So danger signs, we see that the numbers are high. Children that are identified with danger signs, the numbers were high in Karamoja and Acholi. The other regions, the numbers were slightly low. But danger signs, those cases are identified and treated with rectal artesunate. We see that I think only in Lamu, where we had 71%, more than 71%, and that is 77 of the cases are treated. And the other regions, we are still struggling. I think there's so many things we can attribute that to, but at least this is also a point of concern. Pneumonia, those are the cases that we have found amongst under 5 fast breathing and pneumonia. We see Karamoja still records the highest from the community data, followed by Acholi with 23.3. But out of those cases, how many of these were treated within 24 hours? We see that still Karamoja and Kedi are up there, together with Teso, but Kampala still, we see 4%, which is one and a bit. TB and HIV case identification, many of the children seen were found to have been exposed to HIV. The numbers are there, but we see still in which cases the numbers are a bit high. I'm not saying that the cases are many there, but still because of gaps in reporting, this is the picture that we have from the reports that we receive. Same applies to TB. When we were reporting on Wednesday, we highlighted the reporting challenges we had with vitamin A supplementation. But here from the community data, we see that the children under 5 that received vitamin A in the last 6 months, we see that the Kampala data is poor, and also performance is really poor at 7%. But we see districts scoring more than 200%, more than 150%. But there is a need to check out Kampala data, South Central data, and also North Central and Toro. Same applies to Diwani. Kampala is doing badly, as well as North Central and Toro. Immunization, up-to-date immunization status. We see the rest of almost all apart from Uganda and Kampala are doing fairly well, reporting more than 80%, whereas Uganda, Kampala, still way below 80%. This is the distribution of the disability cases identified in the communities by the PhDs. Will be advised by the program if this comes close to the normal prevalence of disability. But this is what we pick from the data that we have. Deliveries, NC visits, and maternal deaths from the communities. We see that the number of home deliveries that we have surprisingly high in Kigezi, in North Central. That is the area of Mubende, Indiana, up there, and as well as Kenya. And we see 1.7% from South Central. Kampala is doing well at 0.1%. Women who attended at least 4 NC visits are also there, with Kenya recording the highest. Kampala still is recording the lowest. Same applies to those who attended at least 8 visits, with Kampala still running there at the lowest, followed by South Central. So I highlighted that those are the villages, the total villages that we have, approximately, and VHTs we have slightly less than 250,000. From the reporting reports that we have, the reporting rates as shown in the figure, we see that North Central is still dragging this when it comes to the 097 bill report. We have a total of 237 approximately, and these are villages. So this highlights, I think, the quality of the data that we have and the reports we have, because the villages are low, but I think this is duplicated across the quarters, and we need to check this. But if you see, Karamoja still records one of the highest, but the highest is Isu, followed by Kedi, Karamoja. Those that are still pulling us behind is North Central, Kampala, Kigeza, Toro, and the rest. So, from what I saw and from what colleagues we discussed